Hi, I'm Dr. Allison Cole, sleep medicine specialist and bona fide chronic insomniac. Welcome to the Sleep is My Waking Passion podcast. Remember, knowledge is empowerment, and if applied correctly, it can help you biohack your way to a better night of sleep, just like I did. Hello and welcome to the Sleep is My Waking Passion podcast. You know who I am. I want to introduce a special guest today. I have Dr. Logan Schneider from Stanford University. He has done a lot of research in idiopathic hypersomnia, which we're going to talk about. We're going to explain what that is for you. And Dr. Schneider is both a board-certified neurologist as well as sleep medicine specialist. So I'm very excited to be able to pick his brain. I actually got your contact information from Dr. Lee Sirkin, who I also interviewed, and I became a member of his organization. So he's put on some really great lectures. I know you did one, but I never got an invite. Otherwise, I probably would have attended that. I think he said you did a webinar.
Yeah, it was just last week or 2 weeks ago.
Yeah, it was very recent. And he said, oh, well, Logan did a webinar. And I was like, okay, how come I didn't get any message about this? I would have gone. Anybody who's listening, I've done some episodes on what we call a central disorder of hypersomnolence, or a very rare disorder called narcolepsy. And idiopathic hypersomnia is in that family of disorders that can be very disruptive to your quality of life, and also fits under this medical category of central disorders of hypersomnolence, meaning it's your brain that kind of contributes to you feeling too sleepy. Logan, would you mind sort of maybe going into more detail about perhaps how common or uncommon idiopathic hypersomnia is, and just sort of a general explanation of what it is for our listeners?
Sure, yeah. So I guess we don't really know what idiopathic hypersomnia is by definition, as the name would imply. It's like your unique pathology causing sleepiness. But we do know that it's relatively uncommon, at least as it's been diagnosed to date. But I think that pertains to probably the same discussion you had when it came to narcolepsy, is that it's probably underdiagnosed because it's often underrecognized. I think we generally consider the prevalence to be about a third of that of narcolepsy, somewhere in like the 1 in 100,000 individuals might have it. But again, it might be underrecognized, most commonly because of the timing of onset tends to be in adolescence, early adulthood type of thing, similar to narcolepsy, often is in women. And because the symptoms are excessive sleepiness and excessive need for sleep, people look at that as a thing you can correct. Well, we've all been sleepy, so get over it, right? And so people look at the aspect like that's laziness, or when actually taking it seriously and taking the symptoms seriously, because it is quite a profound set of symptoms, then sometimes they'll get numerous other diagnoses before they end up getting an actual diagnosis from a sleep physician. Typically, that's who recognizes it. It often looks like depression, or might actually have other medical causes explored that then cause the long course for most patients to be even able to achieve a diagnosis.
Have you, in your clinical practice, being that you are in academia, in community, I would say, like as a community practicing pulmonary sleep person, what I found was I think even though it's supposed to be less common, I tended to see more idiopathic hypersomnia in my office than I think I found narcolepsy, just based on the traditional criteria, if you will, that we use to diagnose it. Do you find that your experience has been sort of akin to what the general prevalence is estimated to be in academic practice?
Well, I think, certainly in academic practice, we have from referrals from the outside community as well as from individuals navigating their way to centers that focus on more unique and rare disorders, that we tend to have an enrichment of these populations. But I think there are multiple other things that might be causing that. One, obviously, is the fact that, a hammer sees a nail everywhere it looks. But to some degree, that's not just us trying to find disorders. Obviously, people are coming into our center with sleepiness, and we know how to differentiate among sleepiness that is pathologic and sleepiness that's kind of run-of-the-mill expected sleepiness, which is one of the aspects of why I think it's underdiagnosed in the community broadly, is because most practitioners, almost nobody has any, or if they do have any, it's minimal sleep training in their medical school education and certainly throughout their residency. I think we have about 2 to 4 hours worth of the pre-clinical curriculum of exposure in most medical schools. And so that highlights that most people are not looking at sleep. And if you don't look at sleep, you don't know how to sniff out what is atypical and extremely atypical and possibly pathologic, or versus what is like normal. And so most people, one, don't ask about it. If you don't ask about it, you'll never be able to think about it and differentiate and go down the right path. And again, also, if you see something that looks like your disorder, and you always think, oh, depression when I see somebody who's behaving this way, then I'll start to treat and manage depression, right? So I think there are many different ways that happens. But even within sleep clinics, if you don't see a lot of these patients because they are uncommon, and the typical workup is assess for other sleep disorders, manage those sleep disorders, and then seldom do you actually find one of these folks. But when you see them, they are very striking in how impaired they are, as well as the biological signals that they the red flags they throw up. Not only just how much they can sleep, which is an epic amount that you or I are not able to do. Our body just stops doing it when it's done, and theirs just keeps going. But also even just looking on our diagnostic studies. So looking at the polysomnogram, when I see a long sleeper type idiopathic hypersomnia, I'm just astounded by the amount of slow wave sleep they have at every ultradian cycle. And they have like 7, 8, 9, 10 ultradian cycles. They just keep going and still have slow wave in there. To the point, though, of one of our major diagnostics, the MSLT, we all recognize that that's not a very good test, the multiple sleep latency test. This is a napping study that, 5 naps over the course of the day to see how sleepy you are. Make sure that you fall asleep, right? That's more of a sleepiness study, not a hypersomnia, which is a long sleep characterization. And if you just did that test in the general population, about 22% of folks would have met the criteria for excessively sleepy on that test, as was demonstrated in the Wisconsin sleep cohort. So it's not a test meant for idiopathic hypersomnia. It was just designed for narcolepsy. And then, well, we have some people who look sleepy but without REM dysregulation. Let's label them and give them a diagnosis. So unfortunately, it's not the right test, even if we see it positive an awful lot.
Yes. Speaking of which, I want to go back to that because I actually have a question for you on that. But you mentioned the community and sometimes the difficulty in really distinguishing sort of relatively quote unquote normal-ish type of sleepiness versus really excessive daytime sleepiness. Can you talk to our listeners a little bit about how you would describe true excessive daytime sleepiness and some of the other characteristics associated with idiopathic hypersomnia?
Yeah, I think, the way I kind of look at individuals with idiopathic hypersomnia as opposed to you or I, where at some point in our day, we tend to feel refreshed and then might get drowsy at some point as a result of whatever, a slight degree of chronic insufficiency, or it's that mid-afternoon dip after you've eaten lunch that's normal in our circadian rhythms, any variety of things. Or maybe just napping behavior that's becoming part of your cultural norm or part of your routine as you age, for example. These folks, they never get rid of the sleepiness is how I look at it. It's one of those things that while they might have bouts of sleep attacks or excessive irrepressible need for sleep where they just can't resist it and they're sleeping at all times or drowsy at all times, but also even when they're awake, they're never really relieved of that sleepiness feeling, right? It's this, I wake up and I'm still sleepy, and that's where they have this concept of sleep inertia, where almost no patient with idiopathic hypersomnia, other end of that tunnel, there is not light, there's just further darkness, but they just have to get up and move on. And so that grogginess, that cognitive dysfunction, that going through life not fully checked in, lights are on but nobody's home type of feeling is part of their waking experience. As they wake up, they also don't like their long naps, again, for the same reason. They wake up unrefreshed. And then throughout the day, kind of go through the molasses of a brain fog, where everything just seems beyond that realm of perception, even though they know it's there, but they just can't penetrate that thickness of cognitive clouding. And so that's part of the sleepy aspect, too, is that they're just not able to actually ever function like you or I. And when they are given the opportunity to sleep, they will take it. If we ask the general question, which many people ask, is how much do you sleep? We all recognize, like you or I in residency, that was never an answer that you could give that was based on how much your body needed. It was how much you were afforded, right? So you
right.
were given 4 hours on your 30-hour call shift to get sleep. And so you're like, I sleep 4 hours, but that's not how much you should be asking about these folks. They are constrained by social circumstances as well to function. They have to be awake for a certain amount of hours. But if you ask them, as Robert Thomas does, how much can you sleep? then you will see the eyes widen, and they're about to tell you the epic stories of, well, after getting 9 hours every day on the week and, clocking another 2-hour nap, on the weekends it's 20 hours of sleep and 4 hours of wake. And even then, they're not able to feel refreshed. So this is the aspect of just like what you can identify as a pervasiveness of sleepiness and sleep in their lives.
This is really, really profound sleepiness that we're talking about. You mentioned the sleep inertia, and that is huge. I actually wanted to ask you about it's kind of getting back to the sleep testing that I've mentioned on some previous episodes. But, when we're watching people sleep and then we're keeping them for the naps, that multiple sleep latency test that you mentioned, and how it was really designed initially for narcolepsy, I've had some folks that are younger, they fit the age group, and they describe really bad sleep inertia, but when I've tested them, they really don't meet the criteria based on MSLT. And it's so frustrating because I'm like, okay, where do I go from here? Like, my clinical suspicion is there, but I don't have the data to sort of back it up. And can I get certain things approved for them? Like, you go down this rabbit hole of not really knowing what you can do from them. And obviously this is, a public education forum, but still just from the clinician side, I'm curious as to how you approach those patients, because I can't be the only person that's seen that before.
Yeah, I think this is a struggle, again, causing the underdiagnosis of what you see it and you know it, and yet you can't confirm it, which is a frustration on our part as physicians, and certainly a frustration for patients not having an understanding or a clear label for what they're experiencing. I think that's one of the major struggles that we have as a field is we don't have a good biomarker, meaning we don't have an irrefutable signal of what this disease is. Hypocretin deficiency, the lack of that molecule in the brain, that's type 1 narcolepsy unambiguously, right? So if it's gone, you have type 1 narcolepsy. Even if you don't have the full spectrum of symptoms, you have it. And for idiopathic hypersomnia, we unfortunately don't have that. There have been a lot of hypotheses as to what could be going on. Could you look for a specific molecule in the brain that's causing this disorder? Could we use better diagnostic testing? Many of the diagnostic tests that we have to date are either considered experimental, like wearing a tracker for your sleep that insurance companies won't reimburse, but sometimes the Fitbit or the CPAP will show me unambiguously that this person's sleeping a lot. Then we also have, as we mentioned, the MSLT, which is not a very good test for idiopathic hypersomnia because it's not meant for it. And as mentioned, a quarter of the population will be positive on that. Every single resident that comes in will be positive for that. And then we also have the underlying polysomnogram, typically the sleep study that we use to look for other sleep disorders that might cause these symptoms, has hallmarks in it that suggest that people are sleepier, but unfortunately those aren't part of the clinical criteria. And even then, when you do these meta-analyses and look at all of the different studies that have looked at sleep and its architecture and the patterns of stages and other aspects about the actual sleep itself in large-scale studies, they don't really provide very compelling results that would be like, this is clear-cut going to be a diagnostic label for these folks. So our field is trying to move forward, trying to find other ways of identifying what the underlying problem is. And so sometimes you have to take a page from the art of medicine world, where maybe if you have the luxury, like in an academic center, for example, to follow one of the protocols like the European group, where they're actually doing these 32-hour sleep, MSLT sleep protocols and finding very excessive amounts of sleep. Sometimes you might want to do what folks like, the Emory folks or David Planty are doing, where they're actually doing a PVT upon awakening and ascertaining, you have psychomotor vigilance impairments up to an hour or a half hour after awakening that are dissipated in the average individual, or doing pupillometry. But these are all, fringe type of things. Typically get a patient on a protocol to be able to do this. Otherwise, it's, maybe pound your head against the wall and try and get the repeat diagnostic test, or sometimes you can default to something like the DSM-5 criteria instead of the standard International Classification of Sleep Disorders, 3rd edition, which is kind of like our diagnostic criteria Bible. There are complementary criteria that come out of the Diagnostic and Statistical Manual that is typically used by psychiatry for most of the mental health disorders, but also has a large chunk of sleep disorder criteria in there. And so if you have a clinically high suspicion, sometimes you can advocate for your patient on those grounds and use then well, if I treat this individual and their symptoms respond to the treatment that is specific to sleep, right, then it's likely that this disorder is a sleep disorder. And so you're kind of using other tools in your bag of tricks to be able to say, hey, one of the ways that we can confirm a hypothesis is, if I give a thyroid medication to somebody who has like a liver problem, they're not going to feel better. The thyroid won't improve.
Right.
So this is the same type of premise. Use a treatment that is targeted to this disorder. And if they improve, well, then at least I've confirmed that they are responsive to this therapy and they shouldn't otherwise be if they don't have this disorder. So sometimes it's, you're just advocating for your patient beyond what are the bounds of what, conventional and criteria-based medicine mandate, because you have a compelling reason to believe that this patient has that.
It's amazing with all the information that we do know, how much we still don't know, especially in this area for sure, hence the name. Can you talk a bit about the autonomic symptoms that you had published and researched, and kind of share with folks some of the other less, maybe less obvious symptoms that might be associated with idiopathic hypersomnia?
Sure. And I think what you're highlighting here is that when you see these individuals, you identify that it's not an isolated issue of sleepiness or excessive sleep, but it really is this syndrome, like a constellation of symptoms that really are characteristic. You pull out narcolepsy, you say, oh man, you have cataplexy, you have REM dysregulation, you have disrupted nocturnal sleep, you have sleep hallucinations, etc. Here, when we're thinking about idiopathic hypersomnia, we're looking at that sleep inertia component, we're looking at that brain fog that is very prominent, we're talking about the long and unrefreshing naps and long sleep durations in general. And then you talk about, well, these ancillary symptoms that seem to be enriched in these populations, right? And we don't understand exactly what's causing that enrichment. Sometimes you can presume that it's the direction of the arrow is a common culprit that's causing both the sleepiness and the autonomic dysfunction. Sometimes it's the suspicion that maybe some underlying process that's causing autonomic dysfunction is also then going to result in a idiopathic hypersomnia. And it could even be the opposite. Because you have idiopathic hypersomnia, maybe because you're somewhat deconditioned from recumbency and being down and flat more than being up and active, that you then end up developing an autonomic dysfunction. We haven't sorted out what the direction of the arrow goes, but we've seen a higher enrichment of autonomic disorders among most of the central disorders of hypersomnolence, including narcolepsy, which might suggest that there's a common underlying cause there. And this work is, I have to give credit where credit is due, is predominantly led by one of my colleagues, Mitch Miglis, who's an autonomic neurologist and a sleep neurologist out here at Stanford. So really wants to marry those two passions. We see that POTS, postural orthostatic tachycardia syndrome, is much more common in folks with idiopathic hypersomnia, but also those vasomotor and orthostatic symptoms tend to be much more prevalent and associated strongly with their quality of life, as well as the degree of sleepiness and fatigue that they experience. So it's one of those things that if you're seeing a patient with idiopathic hypersomnia, I think we should be asking also about any autonomic symptoms that they might have, because maybe even treating those might help ameliorate some of the primary symptoms of the other condition, but also would be worth tracking if those improve with treatment of the primary condition.
Can you just explain a little bit to our listeners what you mean by autonomic symptoms, like what they might be thinking about, just so they're like, okay, what does that mean exactly?
Sure. Yeah, absolutely. So the autonomic nervous system is one of the limbs of your nervous system, and it's by the name automatic in its function. So essentially what makes your heart beat, what makes your lungs breathe when you're not thinking about it, or you don't ever make your heart beat potentially, certainly can control your breathing. It's all the things that your body does on autopilot is basically what the autonomic nervous system is. And so when that nervous system dysfunctions, any of those automatic functions can also have impairments, right? So when I say orthostatic intolerance, it means when you go from a laying position to a standing position, you might feel very lightheaded or even pass out because of that. Other individuals have rapid accelerations of their heart rate that make it unable for them to stay standing for a very long period of time. You can have sweating problems, you can have GI issues, gastrointestinal issues, where you can have very slow progression of your GI function. You can have things where you get develop constipation or diarrhea. Any of the system functions that are on autopilot can be dysfunctional in the setting of an autonomic dysfunction. And so we see those at higher rates in people with idiopathic hypersomnia.
Thank you for sharing that, by the way. That is amazing. I think that would be very helpful because now people can go, hey, wait a minute, what's going on with me? Do I need to be thinking about this? And that's part of what we're doing here is really trying to teach folks how to really advocate for themselves. Because to your point, we don't get the education we need about sleep from the get-go. We have very, very little exposure to it when we're in medical training. And it takes people like us who are sort of really passionate about this topic to talk about it, to hope that other people would say, hey, wait a minute. Okay, I'm listening to this and I'm seeing that there's a lot of symptoms here that resonate with me. Maybe I should be talking to my doctor about whether or not I need to get this worked up.
And now a quick break, but don't go anywhere. We'll be right back.
Struggling with sleep? Dr. Cole is here to help. Whether you need a comprehensive sleeping coach program, suspect you have sleep apnea, or simply seek a second opinion, she's available for consultations in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 15-minute consultation today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted physician.
If you are liking this podcast, if you're finding it educational, if you are feeling more empowered to go to your doctor with any sleep issues that you might be having to address them, please, please, please lend your support. Make sure that you are liking, following, subscribing. I am available on YouTube. I'm also on Apple, Spotify, wherever you get your favorite podcasts. The website has launched. So we have AskTheSleepMD.com to be your free educational resource. We've added many new blog posts filled with juicy information. If you would like to support the podcast, we now have a way for you to donate. This is a labor of love. I truly enjoy what I am doing. It would be inspiring and truly helpful if you wouldn't mind even so much as donating $1 to keep this podcast going, particularly if you really find this free education a good platform for you and a good resource for you. I also have affiliate links for products that I'm a proponent of, such as Quiet Mind. So please check out the website. Sign up and you will get the latest news, the latest blogs, some sleep tips, and just have a great day and keep listening. Okay, guys, sleep well.
You've also done some research looking at the negative sort of impacts on quality of life that folks experience who have idiopathic hypersomnia. Can you go into a little bit of detail about what you found? Because people talk about really being sleepy and you can kind of experience it from that perspective of imagining how a person would feel. But this really does a doozy on how you feel about yourself, your ability to interact socially, your ability to be, productive at work. It has these really profound effects that sort of tether out and affect so many aspects of it. You sort of hinted at it in the beginning, but could you share some of that with our listeners?
Yeah, absolutely. I think maybe it's helpful to understand this from the failure of our ability to step into somebody else's shoes, because I think sleepiness, as I mentioned and alluded to earlier, is one of those things that many people have experienced and have gotten over. And so if you have done it, then oftentimes you can look at others and say, hey, what, as something that's generally out of your control, right? I think we see this in most of the realms of mental health issues, from aspects of like people who have addiction problems, and individuals just don't understand how they can't kick an addiction habit. Sometimes it comes to depression. Like, we've all felt down here or there. It's like, well, do you really understand what depression is? And the answer is often no. I'm reminded by a commercial that came out one time, therapist apps, where individuals were going through the common tropes that people say to them when they're depressed, like, oh, well, why don't you just snap out of it, or melatonin, or all these different things. And I think that's what happens with this disorder as well, is people look at it and say, hey, you're okay, just get out of the sleepiness. And that aspect itself is one of the reasons why I think it's so hard for patients to deal with this disorder and the impact it has on their quality of life, because certainly for those individuals who are intimately tied to them, that can be family members, that can be loved ones, that can be children, they look at it, and typically their experience is, well, I've been able to get unsleepy by sleeping. You sleep all the time. Why aren't you unsleepy? Like, snap out of it. What's wrong with you? Fix this. And so it's often this like social stigma that they start to bear. They start to internalize, particularly when they don't know what's going on, if they don't have a label to like, hey, the stigma's for the thing, not for me. And so I think we also see high rates of mental health issues among these patients because of that impact it has on them. And that then compounds the problem. But then you ask the question of, well, what's it doing to them in other spheres of life? So this is like intimate partner relationships and family. But then it also goes to social engagement when your option is I have to sleep to function, or I can go out and be dysfunctional and checked out with social engagements. Well, then you tend to opt for the one that allows you to function your best, which is often sleep. And so you can be withdrawn as a result of that, or it can impair your ability to access functioning. Our patients don't want to not go to their kid's soccer game. They're just like, I have to make a choice, and the choice is unfortunately thrive or function at a bare minimum, or just, not be there anyhow, even if I am there. And then that is going to have repercussions on my next day and my next day. And then it goes even into their professional engagement, right? So their likelihood of career advancement is lower. Their absenteeism, meaning that they're not making it to work, the likelihood of being on disability is much higher. Or even presenteeism. This is, again, the lights are on, nobody's home. They made it into work, but are they a productive worker? Are they climbing that corporate ladder or advancing in their career? And the answer is not at the rate of their peers. And part of that is through the actual constraints that it places on their life. They're making it to work late. But then it's also because of perceptions of them looking lazy, right? It's like, well, you're always looking drowsy. You're not thinking clearly. You go out to your car to take a nap during the day with the prescription from your doctor to say take a nap, right? And despite that, people perceive them as like non-productive, non-effective contributors. And so, that again creates a vicious circle, right? They have this internalization of hinder their ability to succeed in all spheres of life. So it's vastly impactful.
I know that we call it idiopathic hypersomnia because idiopathic basically is like, we have no idea what causes this. I have read different things about something called the default mode network and, some postulation that the reason that people might develop this might be somewhat autoimmune. Have there been any further mechanisms elucidated? Can you explain a little bit about what you know in terms of why this happens?
Sure, yeah. So I think... Man, it's complicated, right? Again, looking for a biomarker of what this is somewhat confounded by we don't know what it is, so it's hard to isolate it and then get a consistent and strong signal. As mentioned, some folks had looked into, is there a protein in the cerebrospinal fluid, the fluid around your brain, that is inducing this? Like, because we know that there are normal proteins that induce this process. Is it a signaling problem based on how different types of receptors or neurons fire in the brain? And then when you can think about that, you're like, well, is there a global network dysfunction? Can you look at the brain and find a biomarker using functional neuroimaging? And we've looked at that in various ways. Sometimes you can use a metabolic marker, like how your brain uses glucose, the molecule of sugar, and its energy activity. You can look at other radioactive tracers that can go into the brain and say what parts of the brain are active or not, or where is blood flowing or not. And then you can also use these kind of functional magnetic resonance imaging studies, which, they've been around for decades. Back when we were even, not to date us, but probably even back to the undergrad and med school days, these modalities were being studied in research protocols. And have you ever used an fMRI in any of your clinical
not in real life.
No, and I mean, we're talking about high stakes types of problems where what if I could actually use an fMRI to say, is this person brain dead or not? I mean, that is like a high stakes. I'm going to either like let this person pass away and harvest their organs because their brain is already dead, or no, they're actually in there. And even we don't apply it in that kind of a context. It's much harder to even apply findings that are in one study to a clinical domain like this, when even actigraphs, which actually are watching you sleep, are considered experimental, and we can't even get approval for those. So that's the context of like how it's hard to interpret this data. But to your point, this default mode network functionality, I guess, and how the brain cortical circuits interact with one another, it seems like the default mode network is kind of like when the brain is awake but not attending to any specific stimulus, that seems to be engaged at those times. And it seems that there's an imbalance in how the default mode network is suppressed in these individuals based on the functional imaging studies. But again, I haven't given it much credence because it hasn't been replicated to be found like, oh, universally, this is actually clearly the signal that is indicative here, particularly because the default mode network, as you might imagine, it's like a whole brain network that goes into like engagement when people are not attending. It seems to be, varyingly dysfunctional or, elevated or not suppressed or inactivated and overly suppressed in various different states of conditions, like from depression to even maybe the Klein-Levin syndrome narrative. So I don't really know if we can say that this is a strong and clear biomarker in these individuals, particularly given the varying nature of this condition over time. A fair number of people will spontaneously remit symptom-wise from this condition, which is like unusual. And then it gets to your point of, well, is it an inflammatory disorder? Maybe it is, right? In fact, I was thinking, there's a small proportion of people who may have onset in association with a viral infection, for example, that may kick the immune system into overdrive and cause it to precipitate these problems. And in people who report fatigue from various inflammatory conditions, like lupus or rheumatoid arthritis, they can bear a similar narrative of dysfunction cognitively, like the brain fog, but maybe not as much of the sleepiness. I thought the pandemic was going to show this to us. I really thought like, oh my gosh, this is a chance for a mass experiment where unfortunately a lot of people, like the encephalitis lethargica epidemic, are going to come out of this having a persistent hypersomnia and or insomnia, depending upon what parts of their brain that was attacked or dysfunctional. Fortunately, that didn't play out. I'm saying unfortunately because we don't now have a hypothesis and a target to address this problem. So it's unfortunate from the scientific and therapeutic standpoint, but very fortunate that most patients who had hypersomnia and or insomnia symptoms in the context of an acute COVID infection, those often remitted on their own. So I don't think we have a good hypothesis yet or a confirmed hypothesis. We have plenty of good hypotheses, no confirmed hypothesis as to what is the mechanism or what is a good biomarker.
Oh, it's so well said. Thank you for that, because I was waiting patiently to be able to ask you about all this research I've done. So I appreciate that. My eyes have been opened. I just wanted to finish our conversation quickly because, quite frankly, we don't have a ton of medications that we can use to treat idiopathic hypersomnia. The mainstay traditionally has been some form of a stimulant, be it on label or off label. I actually think technically maybe modafinil is the only one that might have some data, but like I've used armodafinil, then you have your amphetamine, various amphetamines that we use as stimulants. And then there is some data for usage of what we call a low sodium oxybate. It's a medication that we can also use to treat narcolepsy, which is kind of interesting because they're not the same disorder, yet we're sort of treating them the same. What I found fascinating is I'm not so sure that people respond as well in IH, but I haven't had enough experience with a lower sodium oxybate just in clinical practice that was my general observation and what I've read. But I wanted to get your feelings on medications and what your experience is with how effective they are in the patient population that you've seen.
Yeah. So I guess, obviously contextually, just to state it again, as it's already been stated, is that none of what we're talking about here is obviously constituting medical advice for anybody. But in that context, right, the previous narrative for how we treated was everything was off-label, meaning the FDA had not approved any specific medication for treatment of idiopathic hypersomnia. And typically that was for medications like modafinil. I think that was the only one that got a strong recommendation. All the others were conditional recommendations, including unusual ones that have small studies that were conducted, things like antibiotics like clarithromycin or flumazenil. It's an off-label and compounded in only one pharmacy. All of them were off-label, but typically our approach was, well, you're sleepy. What makes you not sleepy? Stimulants and wake-promoting agents like modafinil or amphetamines. Unfortunately, those had middling effects, right? They weren't very beneficial in terms of the objective improvements in sleep and wakefulness. And from a patient perspective, they were basically about 50% of the way to good treatment. And so typically we were pounding our heads against the wall to get prior authorizations for these medications. And even medications like oxybate were part of that armamentarium because they had worked in other. And then based on that premise, that was done in a phase 3 clinical trial and demonstrated that it worked in individuals with idiopathic hypersomnia, not only treating their sleepiness, but also treating the whole constellation of symptoms that these patients experience. And then that became the only FDA-approved treatment for idiopathic hypersomnia. So from the standpoint of like how we should treat patients, it should be at least using the standard of care, which is the only FDA-approved treatment in general, is how I at least start my treatment paradigm. But the question I think that is challenging for most people is like, stimulants, wake-promoting agents, that's obvious. You're sleepy, wake you up with a stimulant or wake-promoting agent. How does this medication that makes you sleep more deeply do that? And I don't think we have an objective answer. I don't think there's any data that has yet been collected that demonstrates what about sleep has changed with this medication that ultimately results in better wakefulness, because the symptoms that we're talking about is wakefulness symptoms fundamentally. And so I think the jury's still out. The way I've interpreted it, though, is basically everything that a sleep physician does. Our job is to improve your sleep, to improve your wake. And so I do that with a CPAP. I give you air pressure to stop you from having events that disrupt the architecture of your sleep so that you can kind of go on the ride as nature intended. And then people wake up and they're more alert, more functional in their lives. I think that's the same type of thing that maybe this medication might ultimately be doing in these patients, right? For certain, in patients with type 1 narcolepsy, disrupted nocturnal sleep is a characteristic of their disorder. So you give a medication that's going to improve the disrupted nocturnal sleep, and presumably the day will be better, and it seems to bear out that that's the case. Another factor that I think weighs on that hypothesis is that how quickly do we recover from chronic sleep debt? Well, immediately we'll feel much more alert when we have a recovery sleep, but that's assuming that we have a recovery sleep from an extreme sleep debt. The way that most people sleep is a chronic insufficiency, so a chronic debt repayment of like increasing by 30 minutes is going to take a while to accrue. Well, that's ultimately what those medications do, right? You don't see you see some immediate term benefits, but the long term, it takes, like, if you look at some of the data from 2015 that was published on, monitoring out a year plus with oxybates in people with narcolepsy, that the number of people finally reaching their maximum benefit happened at about a year, right? Which is kind of like my therapeutic target. That's the expectation of how chronic sleep insufficiency with a slight improvement of chronic sleep insufficiency with a medication seems to accrue slowly over time. It's like you're paying off small amounts of the debt. You're not dramatically changing sleep. You're just improving what you're getting to make it maybe 20, 30% more efficient maybe, or more effective. And then it takes a while to see those long-term benefits, even if on a single night you actually might start immediately feeling those benefits.
That is a great point. I had an interview with Julie Flygare, and she, in her book, Wide Awake and Dreaming, she describes how long it took to really get feeling better on her medication. It was not an overnight fix. I've had some folks that feel pretty good pretty quickly, which is always nice. But what you're describing is sort of, if you're seeing a bigger amount of patients in the population, you're going to see that slower rise to improvement for sure. Curious. This has been such a fun discussion. You're such a whirlwind of information for folks, and I really appreciate you taking the time to speak with me. And thank you all for listening. I hope you learned something today. Thank you.
Disclaimer. The statements made on this podcast have not been evaluated by the U.S. Food or Drug Administration. They are not intended to diagnose, treat, cure, or prevent disease. The information provided by this podcast should not be used as individual medical advice. While I am a practicing sleep provider, I am not your sleep provider. You should always consult with your personal healthcare provider for individual recommendations and treatment.